Stakeholder Roundtable on the eve of cannabis legalization. It's a very exciting time, and I think we're just under a week away from a major event in drug policy history in Canada. I want to start today by thanking a number of people and groups. In particular, of course, I want to thank Mr. Michael G. DeGroote for his philanthropic support to McMaster University, and Dr. John Kelton, the Executive Director of the Michael G. DeGroote Initiative for Innovation in Healthcare, which supports the DeGroote Center for Medicinal Cannabis Research. I want to thank Mr. Alan Fine, our research coordinator, who served as the frontal lobes for this event and has done a very capable job in doing so. And I want to thank the staff from the DeGroote Center and the Peterborough Center for Addictions Research for supporting the event also, and Dr. Lorraine Collins of the Center for Continuing Education here at McMaster for providing the venue for this afternoon. I also really want to thank our participants. We have a stellar panel today from academia and from various national and provincial organizations. We have representation from the Mental Health Commission of Canada, the Canadian Centre on Substance Use and Addiction, the Canadian Institute for Veterans and Military Health Research, the Arthritis Society, the Schizophrenia Society of Ontario, Families for Addiction Recovery, the Centre for Addiction and Mental Health in the University of Toronto, and of course the DeGroote Center for Medicinal Cannabis Research. So just to give you some background on our center for people who are not familiar with the center, fundamentally we are supported by an unrestricted philanthropic gift by Mr. DeGroote. We do not receive any funding from the cannabis industry for our central operating costs. We do have some investigators who collaborate with commercial partners, but we are intentionally relying on philanthropy to support our research initiatives to maintain full autonomy and objectivity. We're not pro-cannabis or anti-cannabis. We're pro-evidence and we're pro-science, and we're going to take that wherever it takes us. And the theme today is going to be, hopefully, to think about what we do know, what we don't know, and how we can think about legalization from a critical perspective. Our vision is quite simple in the context of those values, that we really want to promote an evidence-based understanding of medical and non-medical cannabis, and we want to do that using three primary strategies. And I'm going to highlight the first one, which is to develop a nexus of researchers and clinicians at McMaster who are interested in advancing the science of cannabis. And we've been extremely fortunate so far that at Mac and St. Joe's, we've actually had 33 different faculty affiliate with the center. We have representation from across the university, from clinical departments like psychiatry, anesthesia, pediatrics, and also basic science departments like chemistry, pathology and molecular medicine, and health evidence and impact. And there has been enormous enthusiasm, and some of the most active and impactful research programs at the university are now turning their view to cannabis research, an often understudied area. So it's a very exciting time. The center has been able to launch 12 different pilot projects, ranging from novel pilot trials to investigations of different harms associated with cannabis, and is also undertaking its educational mission for the first time this academic year. We have 3 pre-doctoral fellows and doctoral programs at McMaster that are all focused on cannabis research, and 5 postdoctoral fellows also focused. So it's a very exciting time in terms of building that nexus, just 18 months into our genesis. We are also beginning continuing a very aggressive campaign of knowledge translation. And part of that is using our website to try to promote good, balanced, evidence-based information and to combat the misinformation that abounds on the internet about cannabis. This includes a variety of different knowledge translation products, things like research summaries of articles that have just been published, evidence syntheses that try to make sense of a timely topic and give people information they can really act on, as well as deep dive reviews and a premium literature service to give people access to new findings in the field. One of the most exciting things that we're beginning with this knowledge translation initiative is also beginning a certificate in the science of cannabis with the McMaster Center for Continuing Education. And this will actually be rolling out in the spring. It will be 3-course certificate in the science of cannabis. It will, for undergraduates, count towards major degree requirements, and for professionals in their respective fields, be a way to complement their existing expertise and get a deep grounding in what we do know about cannabis. The 3 courses will be fundamentals of cannabis research, risks associated with cannabis use, and also therapeutic applications of cannabis. So we're really trying to, again, take a very balanced approach to what we know about cannabis, both in terms of harms and also ways that it may be useful in terms of healthcare. The last thing I want to say before we get started is a special thanks also to the St. Joe's Research Institute, which also co-sponsors the DeGroote Center for Medicinal Cannabis Research and has been enormously supportive so far. And with that, I'd like to now turn to our panel to learn a bit more about the various organizations represented today. If we could just go through each one, if you could tell us a bit about yourself personally, about your organization's perspective on cannabis, medical or non-medical, and any initiatives that might be happening now that are relevant. Could we start with you, Christopher?
I'm at the end of the table. It makes sense.
Yeah.
Thanks. Thanks, everyone. My name is Christopher Canning, and I'm the Manager of Policy and Research at the Mental Health Commission of Canada. It's my pleasure to be here on behalf of the MHCC today. I actually stepped in for my VP, Ed Mantler, who couldn't make it. He sends his regrets. But I'm going to be honest, I was writing his notes anyway, so you're getting me anyway. The MHCC is comparatively new to substance use and drug policy discussions in this country. So I want to especially thank the organizers, James and Alan, for including us today. While we now have a pretty good sense of what the legalization and regulation of non-medical cannabis might mean for this country, the MHCC is wading into the space humbly and with a focus on public health, harm reduction, and evidence-informed policy and practice to improve the mental health of people living in Canada. As folks in this room may know, in Budget 2018, back in February, the Government of Canada announced an investment of $10 million for the MHCC to study the impact of legalization and regulation on the mental health of people living in Canada. The government also allocated $10 million to my colleagues here at the Canadian Centre on Substance Use and Addiction to also do cannabis research post-legalization. We spent the last few months working very closely with my colleagues there, and I want to thank Dr. Amy Porath in particular and Rebecca Jessman back at CCSA for teaching us a lot about drug policy over those last few months. We've had a really great relationship trying to figure out how we're going to spend this money. It's been a challenge, but it's also been fun, I'm not going to lie. Over the next 5 years, the MHCC is committed to investing in short-term, long-term, and multi-year community-based research projects to help strengthen the evidence base in this country. We hope this new research expands cannabis research specific to mental health and contributes to a more complete understanding of a few areas, these are not all of them, but the social determinants of cannabis use, self-medication of mental health problems and illnesses, the link between THC potency, frequency of use, and age of initiation on depression, anxiety, and psychosis, effective treatment options for people living with concurrent disorders. There are folks on the panel here who do that work very well. The potential therapeutic benefits of THC and CBD on mental health outcomes, as we just heard, the center will be looking at as well. And to some extent, the effectiveness of targeted interventions or universal intervention programs to reduce harms and improve mental health outcomes in the population. Now, the MHCC also recognizes that despite the legalization, ongoing support of research into the appropriate use of non-recreational or medicinal cannabis is needed. And of course, the center right here at McMaster will be laying the foundation for that work. Now, this work is new to us, but we view the legalization and regulation of cannabis as a unique opportunity to close gaps in knowledge and improve mental health outcomes. Over the coming years, the MHCC is also committed to collectively mobilizing the evidence with our colleagues at CCSA and our colleagues here at different centers across the country to share knowledge on cannabis and how that is tied to the federal investments that we're using. And overall, the MHCC endorses a public health approach to cannabis legalization and regulation that reduces harms to individuals, communities, and priority populations who are differently impacted in a legalized environment and who were differently impacted with strict prohibition-based policies. Now, such an approach acknowledges that problematic substance use is so often linked to systemic social, economic barriers and structural violence, including poverty, trauma, racism, discrimination, and other psychological and social risk factors. I attended a harm reduction conference last week in Edmonton, and wow, it was a very powerful event given what's going on in this country with opioids in particular. And this quote comes from a Calgary-based researcher, Dr. Rebecca Haynes-Saw, and she said, "I wish people were as angry about how poverty, trauma, and violence can impact the developing brain as they are about the potential harms of cannabis." This is such a tremendous statement. As I think we'll go on to discuss today, the potential harms of cannabis are tied to a myriad of other risk factors. So as researchers and policy experts, we need to investigate this complexity without falling into medicalized reductionism or fear-based educational approaches to informing Canadians about the harms and potential benefits of cannabis. And a final thought. Cannabis legalization provides an opportunity to create research informed by people who use cannabis and other drugs. These types of conversations, like the ones we're having today, and that we're going to see lots of them over the next little while, need to include people with lived and living experience of drug use and mental health problems and illnesses. And if regulation is being done in the name of protecting youth, then young people have the right to be included in the making of policies, supports, and educational materials aimed at their needs, experiences, and expertise. Andre Picard had a great article the other day, and he pointed out something that the Canadian Students for Sensible Drug Policy has released lately, a new toolkit for educating young people. And he said how much this demonstrates how incredibly wise young folks are about drug policy and harm reduction. And I really encourage all of us to look at young people and listen to them in this process. And I had to add this in, when we engage young people, we must pay them for their labor as experts in consultation. And of course, harm reduction and educational materials directed towards any population, youth, seniors, should seek to inform, not intimidate or scare. The CBC also pointed out the other day, and I was talking to my colleague right before this, that the Canadian Coalition on Seniors' Mental Health is developing a cannabis guidelines to help clinicians advise older adults on safe use, potential therapeutic benefits of CBD and THC, and ways of reducing harms later in life. I think this is really excellent work, and I look forward to seeing where it goes. So I want to thank the organizers again for having us today. Thanks for the opportunity to introduce myself from the Mental Health Commission of Canada, and I look forward to the panel discussion.
Thank you, Dr. Porat.
Well, good afternoon, everybody. My name is Amy Porath. I'm the Director of Research at the Canadian Centre on Substance Use and Addiction, or CCSA. I'm so pleased to be here today for this very timely panel discussion on legalization of cannabis. Certainly a timely topic, and something that is very near and dear to my heart, just given my 17 years working in this area. So I want to thank James and Alan for organizing this important event. For those of you who aren't familiar with CCSA, we were created by an act of Parliament 30 years ago. CCSA is Canada's only agency with a legislated national mandate to reduce the harms of alcohol, cannabis, and other drugs. Our work is independent and nonpartisan, and our mission is to inform decision-making and policy-making at all levels of government across Canada, as well as the front lines of treatment and recovery. Cannabis has been a priority area of focus for our organization since 2008, and a priority area for me for a lot longer. As a scientist, I've focused my program of research on cannabis and drug-impaired driving for the past 17 years. And I'm particularly excited about the opportunities that legalization presents for advancing the national research agenda on cannabis. I really think it's an opportunity for Canada to become an international leader in this area. As part of my opening remarks, I would like to just take a few moments and briefly present on some exciting research and public education initiatives that we're leading at the Centre. So we all know that Canadian youth have among the highest rates of cannabis use in the world. Despite a decrease in recent years, cannabis remains the most commonly used drug after alcohol among Canadian youth aged 15 to 24. We know that youth are at greater risk of experiencing cannabis-related harms. We know that the period of adolescence is a time of rapid maturation and development for the adolescent brain. And the risks to adolescents further increase with the earlier they start using cannabis, along with the frequency of cannabis use, the potency, as well as the quantity they're using. So delaying the start of cannabis use, as well as reducing the frequency, potency, and quantity can really help to reduce this risk among young people. The research also shows us that cannabis use affects cognitive functioning, it impairs our ability to safely drive a motor vehicle, and it is an addictive substance. While there's certainly a lot we know about the health effects of non-medical cannabis use, there remain significant gaps in our knowledge. And this really points to the need for ongoing investment in research, particularly in terms of how cannabis can affect young people. So that's why it's so important that the Government of Canada is investing $10 million into CCSA to further study the impact of cannabis. So as part of this investment, we are catalyzing research and innovation in Canada to study the impact and effectiveness of cannabis policies, regulations, and programs. All this through the development and leadership of a new pan-Canadian network of researchers. And we're so pleased to be working in partnership with Health Canada, the Canadian Institutes for Health Research, as well as the Mental Health Commission of Canada. As we move toward the regulation of cannabis, it's so important that we adopt a comprehensive evidence-based approach to public education. We need to provide Canadians, especially young Canadians, with the knowledge and skills they need to make informed decisions about cannabis use. A comprehensive approach includes programming in and after school, resources for parents, families, and communities, earned and paid media, to really help educate about cannabis use and achieve the best outcomes. It also requires, though, ongoing investment as well as monitoring and evaluation to ensure that it's having the desired impact. Through CCSA's research with Canadian youth, we heard that they want to understand cannabis and receive information that's based in fact as opposed to fear-based. They also want to hear harm reduction strategies so that they're knowledgeable on how they can reduce their risks if they decide to use cannabis. Youth told us that they want to receive information from sources they trust who can speak credibly about the issue, people that we call youth allies. Youth allies can be parents, coaches, peers, healthcare professionals, really anyone who is interacting with young people. So these youth allies have an important role in terms of facilitating discussions about cannabis. We understand that this can be very difficult having a conversation about cannabis, and so at CCSA we've recently released our Talking Pot Cannabis Communication Guide. And this guide, it's evidence-informed. We work directly with young people as well as youth allies to prepare this product. And it really provides a practical approach to talking with youth about cannabis, how to set up the conditions to have a safe, balanced discussion. And I really like what James said about speaking about the harms, but also the benefits to using cannabis, because we've heard from young people that if you're only focusing on the negative, they're going to see right through it. The scare tactics approach simply does not work. So the guide is really intended to help youth allies have an unbiased, informed, non-judgmental conversation and really take that harm reduction approach. So if you're interested, if you're planning to have discussions, and I think legalization is the perfect opportunity to have a discussion about cannabis as well as substance use at large with young people, the guide is available in both official languages, free for download on our website. So I encourage you all to check it out. Thank you again for inviting me to participate in the panel, and I'm really looking forward to the discussion.
Thank you. Ms. White?
Thank you.
Bon après-midi à tous. Welcome everybody. My name is Louise Lumiere White, and I'm a representative, a co-founder of an organization called Families for Addiction Recovery. I have many jobs. My favorite and most challenging job is that of being a parent. I'm here today as a parent with the lived experience of having a child who was addicted to drugs, one of which was cannabis. Almost 5 years ago, our family began a terrifying journey with our 14-year-old daughter. Our daughter was suffering from anxiety and depression, and her emotional pain was too great for her to bear, and she chose to self-medicate. In a matter of a few months, we were faced with a daughter who did nothing but seek her dealer for her next fix. Fortunately, our story has a happy ending because we were able to secure a treatment program in the US to guide us all, our family and her, on a road to healing and recovery. This experience marked us and also motivated me to make a difference for other families with similar journeys. That is why I co-founded this organization. We're short. Families for Addiction Recovery is short form FAR. FAR was founded by parents for parents because the needs of our children, our families, were not being met. Our goals are to support, educate, and advocate. We offer free confidential peer support for parents across Canada. We educate all individuals about substance use disorder and drug policy. This includes the medical community, law enforcement community, and federal, provincial, and municipal governments. We also advocate for compassionate, evidence-based treatment. You might be asking yourself, why is this person who's a nurse and a parent sitting on this panel of esteemed professionals all around me? I've asked myself the same question. But I'm here because my lived experience allows me to have an important perspective on the matter. I get asked a lot, many times, what do you and FAR think about the legalization of cannabis? I believe in it. I believe in a public health approach, just as he was saying, meaning legalization with a strict regulation. That is what we believe is the best approach to reduce the harms and protect youth. However, we would have preferred, thank you, we would have preferred more strict regulation than the government's provided. This is what a public health approach would look like in our view. Number one, the evidence is overwhelming that a minimum age of purchase of 21 reduces harms for alcohol and tobacco because of documented harms to the teenage brain and the increased risk of addiction. Number two, we believe that the product should not be advertised, even to adults, like we've seen with the alcohol industry, which I will point out is also regulated by the government and tops the charts in terms of harms to self and society of all drugs. Number three, we should be educating the public on harms, negative health effects, and safe use, driving, working, etc. Number four, all revenue from cannabis sales should be put towards addressing the immense lack of resources across this country to help people with addiction and mental illness. Youth with cannabis use disorder today and other mental health conditions are currently waiting 16 months for treatment at Pine River Institute in Ontario, the only long-term residential treatment facility for youth. It is hypocritical to care so much about keeping cannabis out of the hands of youth while caring so little for youth with cannabis use disorder. Number five, we need protective health laws so parents can ensure their child struggling with addiction receive treatment instead of incarceration or worse. In essence, we believe that a public health approach to the legalization of cannabis would be the ideal method to reduce the harms associated with cannabis use, especially for our Canadian youth. Thank you.
Thank you. Dr. George?
Thank you, Dr. McKillop. And is this working? I'm not sure. Maybe I'll...
Does it reach?
Does it work? Now that this is here, okay. So thank you, James, for inviting me. And over the last year and a half or so, I've had the great pleasure, based in Toronto, to collaborate with James and his colleagues here at MAC. And I tip my hat to you about not only with your philanthropic center, but the leadership you've been showing within Canada and putting together a panel like this. I think is indicative of the great momentum that's coming together. So I'm here to represent CAMH, which you know is in Toronto, the Center for Addiction and Mental Health, and I guess my colleagues also at the University of Toronto. And we've also taken an evidence-based approach to this, both from the policy level, the clinical level, and in research and education. Those are all collective strengths, I think, at CAMH. And we've also put together things like the low use cannabis risk guidelines. And our CEO, Catherine Zahn, was actually on the working group for cannabis legalization. addiction. So we also treat a lot of people with mental health and addictions. And I've been very fortunate while I've been in Toronto at CAMH to be both the head of schizophrenia and also most recently the head of addiction. So I have seen a sort of dualistic, integrated perspective. And yet the burden, I think, potentially of cannabis on mental health and addicted populations has been tremendous. And not to mention, those with youth, where these disorders often start. So we've tried to take an integrated approach to that, and I've been fortunate to be able to collaborate with people like Amy at CCSA over the last many years, and most recently with Louise at Pfeifer and the folks also at the Schizophrenia Society of Ontario. And so what I would say is one of the real opportunities here is we are going to be perceived as a worldwide leader since we're going to do this nationally. We're the second country to do this recreation legalized cannabis from a national perspective. I think the evidence from the U.S. right now, where certain states have done this, has been mixed. But I think, as you pointed out, Louise, with legalization with strict regulation, that is exciting in theory, but in practice, let's see how it all plays out. And, I think a few years ago, Amy and I and others were able to put together a report with the CCSA on cannabis and youth. And I think, we don't see a lot of truly unbiased, evidence-based reports or even educational efforts in that. So I think, what's been put together by many people in this room, both at national and provincial levels, I think is really important. My own research is in the area of cannabis and other drugs on people with serious psychiatric disorders like schizophrenia and mood disorders. And it's interesting when you do these kinds of studies, particularly, large, or not large scale, but prospective, longitudinal studies, and ask the question, what does cannabis do, both acute and long term, and what does refraining from cannabis or stopping cannabis do? It's remarkable what happens. So what we found in people with schizophrenia and mood disorders is fairly uniformly there are improvements in symptoms, particularly mood symptoms and anxiety and symptoms, and improvements in things that impact on their function, like cognitive performance. So, and yet it's just a drop in the bucket in terms of what is actually out there, in terms of the published evidence, and maybe more importantly, the information that's available to physicians, healthcare workers, and the general public. So at CAMH, we strive to push knowledge forth in those areas and then translate that into practice. So it's an honor to be part of such a panel here, based out of your center, James, here at MAC. So thank you for having me.
Thank you, Tony. Next, we have Dr. Jason Bustos, the Associate Director of the DeGroote Center for Medicinal Cannabis Research.
I'll see if my microphone works. It does. Oh, well. So great to be here. I'm really excited to see such interest. The announcement for attending the event here was not put out that long in advance, but sold out. There's a number of individuals that are also watching from afar. So I think it indicates the immense interest that's currently on this topic for a couple of reasons. One, because legalization is around the corner. 17th of this month, recreational cannabis will become legal. That's a policy that in part has been recommended by government reports as far back as the early 1970s, where there's been recommendations to at least decriminalize personal possession. And I think part of that is increasing acknowledgement that it doesn't make sense to criminalize addiction. It's not a crime, it's a disease, and it should be treated as such. At the same time, I certainly take Louise's point seriously that if there is all this additional revenue that's going to be introduced into the system, it needs to go towards helping those who most need help, particularly with issues around substance use disorders. So that's going to be a priority going forward, I would say. The area that I most come at this from is from the issue of treating chronic pain. I've been working on that for a period of time in addition to acting as an associate director of the Cannabis Center. I'm an associate professor in the Department of Anesthesia. One of the projects that we spent a long period of time working on recently has been the opioid guidelines, trying to understand what role opioids might play in the management of chronic non-cancer pain. That was an area where I think now there's wide recognition that practice got ahead of the evidence. We had powerful analgesics. They worked well for acute pain. Why wouldn't they work well for chronic? What could be the downside? I think it's important as we embark on the enthusiasm that we do see out there for medicinal applications of cannabis, that we take the time to do the science, that we take the time to put the studies together so that we can be very confident in what we provide in terms of information to patients and healthcare providers. I think right now we're at a point where there's a great deal of enthusiasm, there's a great deal of, I would say, hyperbole, at least on the net. If you surf around, you will see claims that cannabis will do everything from cure cancer to reverse autism, and on it goes. But we need to understand which of these claims we can back up. So as James said, the Centre is neither pro nor anti-cannabis. If there's important roles to play, and certainly there have been some recent studies that have come out looking at cannabinoids, CBD in particular, for treatment of certain seizure disorders, there is a developing evidence base that suggests it may play a role for some in terms of helping to manage chronic non-cancer pain. Maybe there's a role for treating sleep disorders, maybe PTSD, maybe a role for some in terms of treating certain intractable conditions that don't have good solutions. We know that about 1 in 5 Canadians will report living with chronic pain at present. We know there's about 6 million Canadians that report living with arthritis, and they're much more likely to deal with the burden of chronic pain. About 40% of those with arthritis will report also managing chronic pain. So the work that we're dealing with from my role in the Centre is focusing a lot on that at present. But at the same time, it's also critical for us to look at the impact of legalization. What's going to happen on October 18th and onwards? Are we going to see use spike? Are we going to see increasing rates of hospital admissions for cannabis-related causes? So these are things we have to look at. This is an interesting product in the sense that it has both a recreational use and potentially a therapeutic use. And so we have to understand the differences, and there needs to be tremendous efforts put towards education. And I think if we don't do that, that gap will be filled by others who maybe are not so unbiased in the information that they want to promote out there. So we certainly have a responsibility to do that and to help consumers understand the quality of the evidence that's being provided to them. And I'm certainly excited to be here today to have further discussions about that very broad mandate. Thank you.
Good afternoon, everyone, and thank you for having me here today, too. I'm pleased to be here, and I'm very glad that you thought of the Arthritis Society for this session. So this is a topic that we have been thinking about for quite some time. I'm glad that Jason highlighted some stats for me around arthritis, because that means I don't have to. But really for us, thinking about those 6 million Canadians that are living with arthritis, acknowledging that many of those people are living with chronic pain, and just to add one more stat to that, by our last count, we know that about half of the authorizations that have been given for medical cannabis have been used to treat arthritis-related symptoms. So all of these are important pieces of information for us. We know that there's been a significant amount of anecdotal evidence. We hear a lot from patients. That's one of our primary roles, to be the voice of patients in many of these complex policy debates. But one of the first things that we also recognized was that there's really a lack of evidence in this area. So we've been doing a few things, for a number of years. So the first thing really is to advocate to federal governments for increases in cannabis research funding. So we've been doing that. The other thing that we've done is we ourselves have launched a cannabis research stream. So we're the first health charity to do that. But through that, we've been able to invest in 2 interesting streams of work. One focused more on basic biology around the endocannabinoid system, and the other really in a clinical trial context. So important pieces of work that we feel. We've also been looking at things around accessibility and access and what that means for costs. So, for example, medical cannabis is subject currently to HST. As of next week, will also be subject to the excise tax, as will recreational cannabis. So, in the context of something that's being used as a medicine, and we think it should be part of a medical treatment plan under the advisement of a healthcare practitioner and such, But in that context, we don't think it's appropriate for that to be taxed. So that's another area of focus for us. The other piece that we've been working on has been around coverage within public and private health plans. February 1st, the Arthritis Society actually announced that we will cover medical cannabis within our own employee health benefits plan. And then the final piece that I'll mention is that we certainly want to make sure that we are providing evidence-based information to people affected by arthritis. So we spend a lot of time trying to make sure that what we're providing, primarily on our website through arthritis.ca, is really reflective of the best available evidence. And we've been doing quite a bit of work in the last little while to make sure that the information that we're providing is updated, reflective of, to be honest, the legalization changes next week. So we've been very active in this area, and we're really excited to be part of this discussion. And I think for us, we're really focused on the medical stream, but obviously the implication of recreational cannabis legalization has really placed an increased spotlight on this work for us as well.
Thank you. Ms. Boudreau?
Good evening, or late afternoon. I'm Erin Boudreau with the Schizophrenia Society of Ontario. I'm the Manager of Government Relations, Policy, and Community Engagement there. The Schizophrenia Society of Ontario is a charitable health organization that supports individuals, families, caregivers, and communities affected by schizophrenia and psychosis. For almost 40 years, we have made positive changes in the lives of people affected by schizophrenia through counseling support programs, educational initiatives, community outreach, advocating for system change, and researching the psychosocial factors that directly impact mental illness. Schizophrenia is a serious but treatable mental illness that has a profound impact on all areas of a person's life. It affects 1 in 100 people, and that's about 140,000 Ontarians. People with schizophrenia are at a significantly increased risk of substance use, homelessness, victimization, and suicide compared to the general population. Despite the presence of symptoms or diagnoses, however, recovery from schizophrenia and other mental illness is possible and is supported by a range of treatments and supports. Given the potential health effects of cannabis use on people with schizophrenia and other vulnerable groups, SSO has developed a position to highlight key concerns and recommendations for its legalization and regulation. To inform our position and to better understand the implications associated with the proposed legislation, we surveyed our membership, as well as individuals who are living with mental illness, and their families and their caregivers, as well as healthcare providers and other community frontline workers. Many respondents welcome legalization as a move away from a punitive approach to drug policy and towards a more health-focused one, which emphasizes prevention, treatment, and harm reduction. Several respondents expressed concern that the criminalization of substance use leads to stigma and discrimination that can have lasting effects on people's lives, and that certain groups, such as racialized communities, have been disproportionately impacted by criminal sanctions related to the possession of cannabis. While hopeful that the legalization of cannabis would ultimately result in a harm reduction related to criminalization, respondents were clear that effective regulations and their strict enforcements are critical to alleviating potential short and long-term health and social harms. In light of current evidence and concerns about the potentially harmful effects of cannabis use on mental health, particularly in adolescents and young adults, some people have concerns that cannabis is being legalized at all. We heard from people whose families have experienced the adverse effects of cannabis use on mental health and are distressed that a substance that is clearly not benign will likely become more accessible through legalization. There is also concern among some respondents that legalization will normalize the use of cannabis, therefore underlying its potential harms, particularly for youth. So what is clear from all of this is that an approach which balances both health and safety while reducing the harms related to criminalization is warranted. As such, SSO values a preventative framework for legalization and regulation that promotes education and prevention, including targeted strategies around mental health in general and schizophrenia and psychosis in particular, that takes an evidence-based health policy approach which aims to reduce health, social, and criminal justice-related harms, and that supports increased investment in mental health and addiction services and supports in further research on the effects of cannabis use on mental health. Thank you, and thank you for the opportunity to be here.
Thank you. Dr. Pedler?
Hi, everybody. My name's David Pedler. I'm the Scientific Director of the Canadian Institute for Military and Veteran Health Research. We're centered at Queen's and Royal Military College, but we represent a network of 43 universities across Canada and 10 global affiliates. And our focus is on research around military and veteran populations. We first came in contact with the DeGroote Center last February, and as soon as I saw the center and learned more about it, I thought, man, this is exactly what Canada needs to help us try and find our way through what is a very, very complex problem. In the military and veteran sector, there has been sort of two real areas of interest. One has been around using cannabis as a medical and health treatment, and the other has been in the Canadian Armed Forces, which has been around cannabis policy in the workplace to assure safety and operational effectiveness. But my comments today will focus probably more on the veteran side. First of all, I want to draw your attention to anyone who's interested in learning more about this to an editorial which was released this week in the Journal of Military, Veteran, and Family Health, and that was authored by James and Jason. So it's a very good perspective on how to approach this issue, the challenge from a veteran and military perspective. So why do we look at veterans and military populations differently? Well, they are unique, and it's especially on the release side of the equation. That's after they're released and they become veterans. They have about 2 to 10 times higher prevalence of mental and physical health conditions. Things like PTSD, chronic pain is prominent. And furthermore, they have access to a unique program, a program sort of like no other that I'm really aware of, where about 7,000 veterans have access to reimbursement for cannabis as a medical treatment. So it does make this population unique, both in terms of access, and then it's one that they've been working on developing policy around. So of course we also know that there are harmful harms and risks associated with cannabis. So from the perspective of our organization, there's really four research priorities that we're most interested in. One is really answering general questions that still haven't been answered around safety, effectiveness, and cost effectiveness. And I think Jason was making reference to that as a priority. And that's that we need to look at cannabis really like any other medication substance. We have to recognize that it has on-target therapeutic effects as well as off-target adverse consequences. And we need to compare it to other pain treatments. That's the context that we need to look at it. The second is that we need to look more broadly at the impact of cannabis on well-being. That would be how it affects functioning at home, at work, in the community. In other words, how it impacts life as a whole, as well as from a public health perspective and safety of use. The third area is that veterans themselves need more information on the potential benefits and adverse effects of using cannabis. And that's, of course, because there's so much misinformation out there as well. So this whole information function is absolutely critical to allow veterans themselves to make the best decisions, especially now that cannabis is legal, and therefore access will be greater. And finally, there's really an urgent need for clinical guidelines to assist clinicians who are faced with questions every day around cannabis use. And are facing a lot of difficulties answering those questions. So those are our research interests, and we're proud to be working with the DeGroote Center to help us support the needs of our population. Thanks.
Thank you very much to everyone. I think that I'm even more confident that we have a really unique panel this afternoon to speak to some of these issues, and your opening comments really highlight how wide-ranging the effects of legalization will be, how they'll affect youth, veterans, individuals with different chronic conditions like arthritis or other conditions that are associated with pain. And I think that the scope of the question is huge. There are approximately 3.5 million Canadians who currently use cannabis. 90% of those individuals are using it recreationally, at least according to the most recent data on medical authorizations. And so they're using it illegally until next week. We know there are harms. We know that it's a risk factor for motor impairment, for bronchitis, for psychotic disorders, and for addiction. About 7% of people over the lifespan will experience cannabis use disorder, but we also know that it does have promise, especially for pain, spasticity, for seizure disorders. And so tonight, or this afternoon, we're really in some ways threading a needle, because we can't use black and white thinking to think about legalization. And I especially appreciate the comments about the opportunity that Canada has on the world stage. We're the 10th biggest economy. We're the only G7 nation that will legalize Canada. The world will be watching, and we have the opportunity to either do this right or do this wrong. So my first question to the panel is, how do we measure that? As experts, what are the indicators that you're going to look at for whether or not legalization will be a success or a failure? Don't make me pick on people.
I'll just throw in there, I think and maybe this comes from my bias as a clinician, but problematic use. There's use, and then there's problematic use, as often comes to mental health facilities like here in Toronto or elsewhere. And we have seen over the last couple of years, and maybe it's one of those things that we just didn't know it was there, but people are now seeking out treatment now that's the case. So I think that's going to be a really important health indicator. But
I think of a couple of the policy objectives behind going to a legalized system were protecting youth, so keeping cannabis out of the hands of youth, but also eliminating the illicit market. So I think those are two areas where we want to look at the indicators. So looking at rates of use among young people, perceptions of risk, mental health indicators, but then also looking at some of those criminal justice indicators as well, in terms of the illicit market, some public safety related indicators, drug impaired driving, and I think we want to make sure we're doing that ongoing evaluation, so that if we find that there's some unintended consequences from the policy change, then we have the data available and we're able to make some changes to the regulations. When we visited Washington and Colorado to hear about their experiences with legalization, that's sort of what we heard from them, is you need to expect the unexpected and make incremental changes as you go. So those would be the types of things that I would be suggesting.
Thank you.
I'll add to that, all important points. A couple things that come to mind is ensuring that there's congruence between the public's knowledge and what the evidence is out there. So there was a survey that just came out a few months ago. The results were from about 16,000 adults in North America, asking them what they thought about cannabis. Over 80% agreed it had health benefits. 10% said it has no risks whatsoever. This is not reality at this point. I think it represents the fact that people are getting a lot of information from sources that are perhaps not entirely credible. So what I would like to see is surveys like that repeated, and to see a better reflection of attitudes out there with the evidence that we currently know is available. Stats Canada is doing some interesting work. They recently released Wave 1 of a specific cannabis survey. Now that's looking at patterns of use, who is using, how are they using it, frequency of use. We've been looking at the data from that first wave, and amongst those individuals that endorsed, they plan on using or increasing use after legalization. Intent doesn't always translate into action, but I think it's important to be measuring these kind of metrics so we understand what's happening. One of the purposes of legalizing or legalizing recreational use was an acknowledgement by the government that prohibition had not worked. You do not get to be the #1 developed country for illicit use if prohibition is effective. So the idea was, let's bring it out of an illegal territory, let these people use it in a legal way, safely, with education and with support. And so ideally, you want to see that actually occurring. You want to see young people's lives who previously had been dealing with a lot of criminal convictions. I mean, there were 55,000 cannabis-related criminal charges levied in 2016. That's a lot. So ideally, a lot of that money that had been going towards prohibition is going to instead move towards providing better treatment for individuals that are dealing with substance use disorder, including cannabis use disorder. My head's still reeling at that statistic you rattled off with. Did you say a 1.5 year waiting list or a year waiting list for
16 months?
16, oh, good Lord. So, I mean, you'd like to see metrics like that go down and more money be reallocated towards providing treatment. If we are going to shift money away from putting all these people in jail and putting through the criminal system, let's see that money is having an impact on doing some good in other places. And finally, I guess you would like to see post-legalization that there is some serious attention put on distinguishing between recreational and medicinal use and establishing clear roles for where cannabis might be able to help people that are currently using without maybe a lot of evidence behind it or a lot of good knowledge behind it. So lots of areas, I think, to look forward to. But if we don't measure it, we can't evaluate it. So that's going to be critical.
Maybe I'll just add to that. I think one of our goals, too, in this context is, as we talk a lot about recreational use, let's not forget the opportunity here to learn more about what the medicinal opportunities are, to make sure that we're providing a good evidence base to inform clinical practice guidelines and such. So when we look at all of the significant interest right now, I think one measure of success would be that in this recreational context, to make sure that we're still learning about medicinal cannabis and what implications there are and how we relate these two different streams of activity.
If I could just add, I don't know, is this on? Hello? If I could just add about surveying Canadians. In Portugal, when they decriminalized in 2011, I believe, if I have that date correct, they surveyed the Portuguese community, and I think it was 10 years later, and they said they didn't want to go back. And that was a major ordeal for that country to deal with. Now, 1% of their population was addicted to heroin, so they had to do something. But that would be, for me, one of the best indicators is surveying every Canadian or the average Canadian saying, are you glad it was done? What does it mean for you?
I'm repeating some of the comments that have already been made, but in terms of failure, certainly if we're seeing an increase in individuals who are seeking mental health care as a result of a cannabis-induced psychosis, for example, how long are they waiting for? Right now, we've been struggling for years and years and years with a system that is at capacity. Are we going to see an even heavier burden on our healthcare system to respond and treat individuals who are having an adverse reaction? Of course, the number of accidents caused by driving while high. We know that there are many Canadians who still think that driving while high is not as dangerous as driving while drunk. And the overall cost of the mental health and addiction system, are we going to see an increase in that? In terms of successes, it would be very interesting, and perhaps this is a pie-in-the-sky dream, but because it's now legal, maybe with the increased access, people might not be using as much as we're anticipating that they might be. Who knows? They just want to put it out there. And certainly the number of people who are in fact diverted from the criminal justice system, particularly youth. And key there is, at least at the provincial level, ensuring our police are equipped with the tools and resources that they need to effectively and properly divert particularly young people out of the criminal justice system and into services and supports. And then also an acknowledgement based on data collected by the government for an investment into our mental health and addiction system, and certainly an investment into more research in this area.
And I was just going to make a comment about treatment seeking, because we already know that from research on veterans, but on other populations, that often people delay treatment seeking for mental health treatment. And so if cannabis, once cannabis becomes legal, there'll be no need to even go through a physician for authorization. So, and if everyone already believes that cannabis is a highly successful and effective treatment, you could easily run into many more people treating themselves with cannabis rather than getting a proper diagnosis and proper treatment follow-up. And so, so that's a major concern that I would have, although I don't know exactly how one would measure that.
Those are excellent points. Jason, do you have something to add?
That's a really great point. There's this tremendous chaos out there right now. You get representatives from the Canadian Medical Association saying after legalization, they're out of the medicinal cannabis business. You have representatives from the Ontario Medical Association approaching our centre to develop educational material because it's the leading priority of their members to hear about. So I think right now you've got a very strange situation where people have to decide what happens post-legalization. When you do survey people that are currently using, and we do have around 3.5 million Canadians, it's very difficult to find a pure sample of people that only endorse use for recreational or only endorse use for medicinal. You often have a combination there. So I think there will be an interest in people continuing to sort of access recreational products to try to self-medicate, but as we learn more and more about the different constituents of cannabis and the various cannabinoids, I think that it's going to be incumbent upon us in this room to make the distinction to individuals seeking care, to let them know that medicinal cannabis might be very different from what they'll be able to access recreationally. I mean, there's a number of the medications that are just starting to get approved are almost pure cannabidiol or CBD, which has no euphoric properties whatsoever. You are not going to find that for sale in a recreational outlet. So I think another metric is going to be really making that distinction, bringing healthcare providers into a situation where they feel comfortable talking about this issue with their patient and providing them with good advice and making sure that there is that distinction between a recreational and a medicinal market.
Sorry, I'm sure you want to move on, but I just wanted to add to that because one of the realities from the patient experience is that even though medicinal cannabis has been available for some time now, it has not actually in practice been available to many patients because their physicians are not comfortable prescribing or giving authorization for it. So for sure, there's a big education piece around this, and I think what you just described is a really interesting point for us to think about how do we empower patients, and in some cases in this context, it's to ask the right questions with the right information to approach the subject.
Excellent points all. I think that one can envision a Canadian cannabis report card out of those responses, right? So there's a variety of indicators. There's no single way that we're going to measure success or failure, but really it's going to be a matter of looking at upstream indicators like attitudes and perceptions, as well as real-world clinical indicators like people presenting for care, people reporting substance misuse, and also systemic indicators like the extent to which we can have a fully realized recreational system and medical system that really is meaningfully different and attracts the right people to each of the two systems. That brings me actually to the next question, which is, what should medical cannabis look like post-legalization? There's a lot of attention paid to non-medical cannabis, but as Jason raised, the CMA has made the argument that it should actually be unwound and simply be part of the recreational system. I'd be interested to hear the panel's perspective on what is an optimal medical versus recreational system in a two-system environment post-legalization.
So I would just say for us in a post-legalization environment, we would absolutely think that a medical stream should be maintained. And there are many different reasons for that, but fundamentally we believe that if something is being used as a medicine to treat a chronic condition, it should be monitored under the care of your healthcare practitioner and otherwise. And that's fundamentally where the perspective comes from. But of course, there are other implications to that. Around what does that mean for taxation, as I mentioned at the very beginning. What does that mean for healthcare coverage? What does that mean for access? Right now, the only way that patients can access medical cannabis is through mail order. So for all of those reasons, we think that it's important to maintain a medical stream, but hopefully legalization will actually improve some of these aspects that we've highlighted.
And maybe just to add to that, there's There's really three parts to drug development. I mean, you want to know that something is of high quality. If they're making it one time, they can make the same thing a second and a third and a fourth time. You want to have confidence about the safety, and you want to have confidence about effectiveness. This is a plant, but it's not the first time a plant has been the basis for creating a drug, right? When we feel an ache or a pain, we don't go out to the forest and find willow bark and chew on it. We get an aspirin. Someone found that had properties, they derived the active component, and now we know what we're getting. You know the dose, you know the quality, you know what the safety profile is. This has started to happen now with medicinal cannabis. The FDA just approved the first cannabis-related medication a few months ago. You've heard it mentioned here, Epidiolex. It's 100% CBD for all intents and purposes, but that was purified and extracted from cannabis. It was administered in the context of a clinical trial. It was done in a high-quality setting. The results were compelling. It was published in the New England Journal of Medicine. And now we have a drug for individuals that have these certain types of intractable seizures where they know if other treatments haven't worked, this is an option for them, and they know what they're getting. And it's simply prescribed as would any other kind of medication. There is some complexity with the cannabis plant because we don't know if things work in isolation, if they need to be combined with other components, but we can study these things. And I think right now in the era of legalization, where it is now you can get it, you can study it, we can start to look at components, cannabinoids within the plant that appear to be promising, and then we can take those and administer them in both preclinical and ultimately in clinical trials and find out what works, who does it work for, and at what dose. So I think if we embark on this, it's going to become less of a plant, and we're going to come out with a set number of products that have been quantified that are going to be more comfortable for clinicians to talk about with their patients.
Thank you. Excellent points. I want to go back to another issue raised earlier, which is around resources. And will resources be made available post-legalization? In the history of drug policy, when it comes to recreational drugs, there's historically been the privatization of profit and the socialization of risk. That is, people use drugs and often require treatment that is ultimately underwritten by the public sector, but the private sector benefits from marketing and selling those products. I'm curious to hear what the panel thinks are the resources needed post-legalization in terms of maximizing public health and what the role of private industry is in that, in those resources. Louise raised some very interesting, a very interesting proposal to start with in terms of where tax dollars should go, but in practical terms, what should this look like?
Personally, I have some concerns about the private industry getting into the treatment because it's not regulated. And we do have some stories from families who sent their youth or child, whatever age, to a facility, and it wasn't evidence-based practice that they were doing, and there's no regulation. So that's a concern of mine. If it starts popping up left, right, and center that we have these private facilities for youth because Pine River can't accommodate it because we don't have enough beds, that 16-month wait, who's going to regulate that?
So cannabis should not be easier to access than mental health and addictions care, yet in many ways it is, and perhaps might become even more so with legalization. So as such, the federal and provincial governments, as I mentioned before, should invest all proceeds from revenue from cannabis sales into the mental health and addiction system and reinvest related cost savings by earmarking a portion of revenue from cannabis sales for investment in community mental health and addiction programs, target investments in treatment for concurrent disorders, CUD, and youth-specific services, invest in social or supportive housing, employment supports, income and food security, and building capacity for acute care and inpatient units to deal with a potential influx in cannabis-related cases, and then also redirecting resources that are saved from processing cannabis-related possession charges into more effective diversion programs. And then on the public health campaign front, No question, Health Canada should be providing immediate funding to all the provinces to support comprehensive and cross-ministerial public awareness campaigns to increase knowledge of cannabis and the associated risks. Provincially, the Ministry of Health and Long-Term Care should be collaborating with other ministries, including Children and Community and Social Services, the Attorney General, Correctional Services, and invest in a comprehensive prevention strategy. And that includes working with schools and campuses, to name a few. And I think with all the education campaigns as well that the government should embark on, that should really include input from youth and youth with lived experience as well.
Just one point to build on that. I completely agree with the public education. The further point I want to make, though, is it needs to be sustained. So I'm hoping, several years from now, post legalization, we still have public awareness campaigns that are running. It took us 3-4 decades of the drinking and driving messaging to get out and bring about that sustained change. So that's an important piece. We just can't run public education ads for a couple of months and hope it sticks with Canadians. In addition to public education and treatment, I think we also need to consider the resources for the enforcement of the new laws. So police officers, the training, the labs that are going to be testing the samples of the drug-impaired drivers, and then also the research. We need to make sure that there's funding set aside so that researchers can look at both the harms, but also the potential medical benefits of cannabis. So lots of areas where we need to invest sustained funding post-legalization.
Yeah, I really like this conversation. And just one more part from the mental health side, I agree that there's a lot of really good promising practices in the community right now for young people, including the integrated youth service model that's been developed in BC and in Quebec. And so I think some of the money going back into meeting young people where they are in the community and the needs that they have. So programs for 15 to 25-year-olds, which is the demographic we're talking about here, and it's shown promising. Another area of investment might be to publicly funded psychotherapy programs with concurrent disorder focus. We've been looking at policy options to expand public funding for psychotherapies across this country. Ontario is working on a program right now. But again, the mild to moderate and those early interventions for young people would be really, really good place to invest this money.
And just as a slight acknowledgement to I think the current situation will be better than the past situation, where all the proceeds went to organized crime, who are very bad at paying taxes, and all of the harm was being underwritten by society already. So I at least now we know where the money is going to be going. And this is not a trivial market. The estimates are about a $7 billion market per year. There's a reason on every block you see a new cannabis company sprouting up these days. People are anticipating substantial revenues, but that's revenues that can be taxed, right? And that's money that can be then put into areas where it can do good instead of funding, another mansion somewhere for a drug czar. I do think that we can learn lessons from other jurisdictions and even countries that have embarked down this path. You heard Louise mention the example of Portugal. Well, they decriminalized personal possession almost 20 years ago. Now, they didn't just decriminalize, they also embarked on educational programs to keep drugs away from youth, programs to still criminalize illegal distribution of product. So they had to do a lot of things in order to make it work. But they saw a net financial benefit from before, when they were only policing and it was illegal. They ended up spending more as a society than when they decriminalized and put their money into treatment and also into education. And they saw the number of heroin users in that country go from 100,000 before decriminalization. Now it's down to 25,000. And they have the lowest rates of drug-related overdose deaths in Western Europe. So if you do it right, I think you can see a net benefit, but you can't just decriminalize, you can't just legalize, you need to have these other programs in place. And with all this money coming in, who knows, maybe $7 billion per year, there's a lot of funds to support these essential programs.
How do we make sure that happens? How does the public sector and academia and the general public ensure that what will almost certainly be a large economic boon nationally actually turns into public health benefit?
continue with the advocacy work that we have been doing over the last decade to demonstrate what works in the community for mental health services and supports. I don't think we need to go to bat with industry, but there's evidence out there that works, and we need to demonstrate that to governments. We need to demonstrate that to folks in the industry.
Just to add on what has been said, I mean, I think, Christopher, you're sort of alluding to comprehensive education, treatment programs, and, you know, when people develop problematic use of any drug, there's often associated social, you know, cultural, and, you know, clinical factors that you know, including familial factors that come in. And, you know, we're never in addiction treatment just treating an addiction. We're treating a sort of bigger picture. Mm-hmm. And so I think with recreational cannabis, you know, there's tremendous opportunity to reduce harms. And, you know, I think the recommendation that there be clear labeling of what the product contains is really critical. But that's not going to go far enough if people don't know what the discrete risks are from, say, a 30% product versus a legal 15% project. Because if people are given the option, you know, and their outcome is which one will get me more high, of course they're going to choose the higher risk, you know, more satiating product, right? So, and I think a lot of that basic education is not there for both the general public and, most poignantly, I'll speak as a physician, for physicians. So it's interesting that we had the Canadian Psychiatric Association conference a couple of weeks ago in Toronto, and normally when we've done the addiction sessions, there would be maybe in a room that could hold 220 people there. Now those rooms are packed because physicians, and I'll speak for psychiatrists, are starting to realize, wow, our populations that we treat, this is a big issue and it's going to impact on outcomes. So that is a very positive thing, but looking forward, how do we keep this momentum going? Like you said, Amy, how is this sustained? So if we just put up $10 million for the next 5 years, or in this case, 82 million was what was put forward, you know, but that's great, but the reality is that's about 50 cents per head per year per Canadian, and that's probably not going to do it. So what is the role of the private sector who's going to make billions of dollars on this? I think that needs further discussion, and I think right now those conversations are not happening.
And really simplistically, at the mental health care provider level too, I think now more than ever, it's going to be incumbent upon providers to really track data and stats. What are the nature of calls that they're seeing, the cases that they're seeing? Track those numbers, because that's your argument to government for further investment in mental health services as well, if you can demonstrate an increase in need as a result of legalization. But I think across the board, mental health service providers really need to be paying attention to who's calling and why after legalization as well, to help with some government relations and advocacy.
And so I'm just going to jive off that. Someone mentioned this earlier, but it's really imperative to look at the social determinants and who is responsible for public health and the health of populations with housing, food insecurity, poverty, racism, all these things. Who is responsible post-legalization to look at that? And I don't think I've heard a satisfactory answer on what will be the public health response to talking about those complex lives that you were just mentioning. It's not just a single disorder. It's usually a very complex life that people come from. So how will this money look at the full public and where the public come from, including their lives and their financial lives and all those things?
I think this was mentioned earlier, but I think you will have to elevate the public understanding of harms and benefits to leverage political and to establish investment as a priority. And I think probably quite far behind the 8 ball on that already, because most of the public that I know already thinks that this is a great thing for many reasons, and certainly from a health perspective, that it's positive and it's already been sorted out. The evidence is already there as far as many of the civilians I know think. So I think addressing that will be really important for priority setting.
And maybe just to go back to sort of the fundamental question about what could industry's role be in this. If you're a researcher funded by public dollars, there is an expectation that you make the results of your findings publicly available. And there are models out there where industry works with academia, and that type of work would be available in terms of open access results, et cetera. So I think that's something that I think we should be thinking about, because in terms of the potential for that to impact the evidence base, to make sure that it's all out there, I think will be important.
I think that's a great point, and I want to dig a little deeper there, because I think a question that we hear now is, what is constructive and positive corporate social responsibility in the era of legalization? What are the right models that we should use? And what should it look like? What are the safeguards we have to have in place to ensure that there's transparency, that data collected are available and not buried if they're not supportive? I'd like to hear from the panel what people think this would look like in a best case scenario.
Well, for some bad news. So there's a lot of information that's never published, unfortunately. So that's sadly true. We our group looked at about 1,000 trials that had been launched in the year 2000, and then 12 years after they started, about 54% had ever been published. And we know, unfortunately, that negative trials tend to get buried, positive trials get put out there. So it's an ongoing challenge. But what I will say now is, certainly at McMaster, we are not permitted to engage in a contract with industry unless we retain the right to publish. And I've been through this battle personally, so I can tell you they take it seriously. Certainly the first thing that we have in terms of a point of introduction to any industry partner that's a potential collaborator is to simply put that policy right out there. You know, there's a potential for us to collaborate, but any research will be published regardless of findings. It's not dependent on findings. So I do think that that needs to be a rule that's in place. Now, there's a number of contract research organizations might not feel sufficiently rigorous about engaging in that policy every time. So I think right now it's incumbent upon people looking at evidence and journal editors to demand that clinical trials have been pre-registered. There are lots of places now that can do that. It doesn't cost anything, and basically it allows people to understand, what did you say you were going to do, what trials were launched, and if they weren't published, you can go back and say, well, why wasn't this published out there? So I think that in terms of academia, there's the ability to demand that in terms of any relationship with a industry partner. I think in terms of journals, editors will now demand that. There are certain journals that will not publish the results of clinical trials unless they were pre-registered, and they look back to see, well, what did you say you were going to do and what did you actually do? So I think if we enforce these things, we can go a long way to ensuring that the evidence gets out there. But it's always going to be a challenge, I think. It's always going to be a moving target.
If I could turn to Tony, you're deputy editor of one of the most prestigious addiction journals, Neuropsychopharmacology. From that vantage point,
Yeah.
What is your perspective on exactly the issue that Jason raised?
So in my perch as a journal deputy editor, the journal that James is referring to is Neuropsychopharmacology, which is a psychiatric neuroscience journal based out of the US, associated with an organization called the American College of Neuropsychopharmacology. And we got tremendous resistance when the editor-in-chief and I started to require registration, and in particular from commercial industry, who said, in other words, trust us on this. But change is slow, cultural change is slow, and now, this is in the last year and a half that we've done this, that's starting to happen. And most of the major journals, at least in psychiatry, and I suspect in pain, are requiring this right now. I think the big concern, just to build on what you said, Jason, is, with this bonanza that is going to be, the commercial, recreational cannabis, how much transparency will be adhered to? And, already I'm hearing from colleagues, who, companies like Canopy and Tilray are approaching, and would you do a CB trial with us, the conversations around, well, what happens if we don't get what we hoped, right? Will we still be able to publish this? That, you think that that's something that we could just assume that is not necessarily the case. And like I said, in the bonanza that's going to be the commercial aspects of this, the financial gains, that is a real worry. So I hope, governments, the federal government, other provincial, local governments keep that in mind as they accrue tax benefits, because we don't want to throw the baby out with the bathwater. And there's tremendous opportunities. I'm sure Epidiolex cannabidiol will get approved in this country, and once it's approved, like I'm hearing from American colleagues, physicians can prescribe it for whatever they want. So I know colleagues in the US who are now giving CBD, now that it's approved, to PTSD patients and schizophrenia patients and depressed and bipolar patients, because they heard, hey, maybe it might work, and nothing else is working. So great, but where's the evidence? And I think that's where the regulatory framework that comes with the tried and true publishing standards and surveillance and transparency goes a long way. So it's a work in progress, and I think every journal is struggling with this right now, mostly because we're all afraid that if we're too restrictive, they'll go to our competitor journal. And
That's right. And I think that the reality is that there is, an economy of competition, and there are non-overlapping interests. The question is for the public sector, how do we create a framework in which there are models of positive corporate responsibility in which the fox is not in the hen house, and we can actually promote good science with support from private partners also. I want to raise a question that was, or I want to go back to a comment that was made earlier about individuals who have been disenfranchised as a result of illegal cannabis, people who have convictions on their record, and especially how the criminal justice system disproportionately falls on certain individuals, especially individuals who are vulnerable for other reasons too. I'm curious what the panel thinks about how we now address those challenges after legalization, when suddenly the rules have changed and people have had adverse consequences as a result of the previous law, but now and now may still have to live with those consequences.
I don't know the legal ins and outs of it, but the federal government has hinted at full amnesty for criminal charges. So I think that we should continue to follow where the federal government goes there. That seems like a promising, they're following suit. I think it's California who led that. So it seems fair, like a realistic and fair process for now, full amnesty.
the other thing I'll just point out, maybe this is a potential elephant in the room with legalization, but on the law enforcement side, I think that's been brought up. The tests, the impaired driving test may not be, fully, the perfect test like we have with alcohol breathalyzers, right? And clinically, right now, when we determine abstinence from cannabis, we set a threshold of 20 nanograms per ml, and yet with this driving test, I believe impairment is above 10. So there's a little bit of a discrepancy there, and I've already heard from folks in law enforcement that not all of them are fully comfortable with this. And my worry, and Christopher, you mentioned cannabis amnesty, which I think is the right thing to do if we're changing the laws. Then people who suffered under the essentially prohibition should. But then are we going to create a new class of people who are driving along on a local road and rear end someone, and if the police have probable cause and say you're a recreational user, they're going to test their saliva and they'll be above the 10 nanogram per ml limit, even though they weren't technically functionally impaired. So my worry is, while there's going to be amnesty, there may be a whole new class of people who suffer from the laws that will be coming up to enforce legalization. But that's controversial.
Yeah, I guess I've heard of the Californian approach, and it certainly seems to make a lot of sense. I'm surprised that the government, we're like a week away from legalization and they still don't have a clear policy on that. Yeah. It's a little odd. I think they're just playing catch up in so many areas that they're feeling a little bit overwhelmed. It is interesting with this sort of testing right now that's going on to try to establish, well, who's impaired or not. One of the problems with THC is it sticks around in your system an awfully long time, right? You might have exposed yourself to a product a week ago and you still show up positive for something. One of the sort of odd things that the Toronto Police Department has now just said, can't come into work if you test positive, within 28 days of your, so don't come into work until it's been 28 days since you last used. I mean, it's essentially a ban. They're saying don't use it, right? I mean, imagine saying, well, it's okay if you have a beer after work, but wait a month before you come back into work. I mean, that's kind of where the policy is now. So I think there's going to have to be an adjustment. There's going to be a calibration. Right now, it's sort of too extreme in certain cases. And I think there's a lot of attention right now trying to figure out how to get it right. So that's, I think, in progress.
Yeah. Thank you. I'd like to now open the floor to the public and welcome any questions about legalization. We have a very august panel here, and we still have plenty of time to discuss any questions that people might have. Just as a point of order, I will bring the microphone to you if you have a question, just because we want to make sure that people who are live streaming can hear you. But at this point, does anyone have a question that they'd like to pose to the group?
Thanks very much for your comments. I have a question about what students in the healthcare system and hospitals and staff in hospitals. What do you think what we should be doing about medical residents, staff? We've heard about disparate police services, and that seems to be, from 28 days to just don't show up impaired. But when the rubber hits the road, it's often when you're lying there in a bed and you've got the person look after you. What do you think we should be doing with our university students and trainees in the healthcare system in terms of using marijuana while working?
I'll start things off. I have some mixed feelings because, I think one of the struggles we have in medical education or student education is getting the facts right and having robust opportunities. And what's interesting, when I've gone to talk to student groups, Franco Baccarino, who's the president of the University of Guelph and leads our CCSA scientific advisory group, he had me come up to University of Guelph last year, and what was lovely about that is I got to interact with students who have thought through these issues very well, and would say, and I hear this from medical students, from residents, but we don't get this within our curriculum, and and also I experiment with this. I see its bad effects. I've seen friends who had its bad effects, and so we're still all over the place in terms of setting expectations for what information is available to students at all levels, and to me, it comes down to, if you have the evidence and you can think critically about it, which is what we should be teaching our students to do, let them come up with, decisions based on that, right? And I think sometimes these things just get, presented as fait accompli, cannabis bad, cannabis good, and there's no critical thinking of that. So I don't know if that speaks to your question at all, Gary, but it is a struggle, because I think, just like we talked about sort of, when we treat a patient, it's not just their cocaine or cannabis, it's a bigger picture, and I think we have to take a bigger picture when it comes to educating our young people.
That was exactly my point. I don't know if I think your question around cannabis specifically is good. I don't know the days, but I think we need to situate this in the context of all substance use and impairment in the workplace more broadly, which can include stress and fatigue and mental illness. And I know there was a CMA report the other day on depression rates in doctors. And so mental illness and mental health problems also cause impairment in the workplace. So put this in the context of what standards do we need for young trainees to be safe and taken care of in the workplace to learn. And so cannabis is one piece of that, and it's interesting because it's legal now, but I think we need standards broadly around protecting people in school settings and for them to be safe and not impaired in any way, shape, or form.
And just to add to that, I think the real concern is not that someone has some trace amount of a metabolite of cannabis in their system. I think it's that you don't want them coming in impaired so they can't do their job properly. Yeah. And so I think, we have an idea about the pharmacokinetics of THC and how long it stays active. We know if you smoke it, on average, that feeling of euphoria is going to be about 1 to 3 hours. If you consume it, it hits you later and takes longer, but 4 to 8 hours later, most of that euphoria will have gone. I think we need to provide better information about how long the associated incapacity will last. Add on maybe a standard deviation or two to really make sure that you've been very conservative in terms of when the effects are going to be going to, and then it becomes like any other recreational substance that's legal out there, right? You expect people are going to manage it. If they're not managing it properly, then that needs to be part of the workplace management that's occurring, as it would with someone that maybe is coming in with alcohol on their breath or acting impaired due to other reasons. So again, I don't know if we're going to come up with a perfect test for impairment, but I think we can provide good education about how long the impairing effects of this product are going to typically occur based on different ways of taking it in.
First of all, congratulations on this meeting. I think it's fantastic. It does a power of good. It's timely, and it's about a year late because we should have been having this maybe a year ago. But I think the issues are clear for me. This is a place where evidence-based medicine is important. It's driving many of our activities here in Hamilton. It's clear that you can run that process when you're doing a controlled trial with a divine drug that you will come up with an evidence-based outcome which will be able to inform policy, it'll be able to inform the clinical populace as well as the public. So there's good control there. 2 weeks from now, the natural experiment starts. You have no control over it whatsoever. There will be the data that's getting generated day by day on the anecdotal basis. Numbers are going to increase. If you like, the opinions are going to be expressed. How do we really control that to really the people we need to, which is the government? The government is going to make policy decisions, and two of you up there are responsible for making recommendations in terms of policy. How do we really interpret that natural experiment outcome vis-a-vis the kind of that we can control? CBD is or is not capable of modifying pain in 2 or 3 conditions. Fine. But what about the natural experiment? What are you going to do? All of the people with arthritis tomorrow are going to start generating the data, their own data, and it's going to proliferate. And maybe it's the cat out of the bag now, and we can't control it. But it's going to have a huge influence on the policies that are going to be taken by the government. So I would encourage this panel to get very active and write a series of op-eds, all of which are targeted towards evidence-based outcomes that can be factually proven, and make that on an ongoing basis to the government so that they cannot overnight say, well, 300 people in Chibougamau have told me that this is going to be a great thing to do. We have to continue to push that, and I think this panel or a panel like this is where we should start, and op-eds on an ongoing basis towards the public. I think are a very critical element.
Does anyone want to respond or comment? Because I think that was both comment and question.
I have a feeling I'm going to say the same thing that Vikas is. Are you going to speak about the registry? Okay. So if you want, okay, well, now I've said something. So you're 100% right, and we've been thinking, how can we capture this natural data so that we can inform what's happening out in the real world? There is a Quebec cannabis registry where anybody that was authorized to use cannabis were mandated to put in outcomes, demographic data, follow-up data on outcomes. So there is at least a partial model in Canada for how that could be done with the Pain Centre, with Vikas, with other individuals there. We've launched now a prospective cannabis registry for people that are being authorized to use cannabis for chronic pain, and that's now been branched out to a number of other academic pain clinics, and hopefully going to continue to expand that to get that kind of natural data. As I mentioned earlier, we are very heartened by the fact that Statistics Canada has now created a cannabis-specific survey that they are going to continue to launch out in a number of regular time intervals every year. But more of that has to be done, and they have to use that data, and they have to use it to inform policy. So I think you're exactly right. We have to get involved in accessing the data that's coming in. We have to mine it. We have to put out information based on it. We have to encourage more of that work to happen, and we have to look to encourage, not just put out our paper and say mission accomplished. We have to get to the policymakers, bring them into the room, into that dialogue. I think some of those people are here today, and say, listen, we think we can help you to inform policy that's going to be supported by the available evidence we have. And once those policies have been put in place, let's measure the impact, because all policies are enacted to try to create a change. Again, if you don't measure it, you never know if you've been successful. So it certainly has to be a priority, I think.
I just wanted to add to that quickly. I think your points are really well taken. And one of my worries, and it's great that you guys have created registries, there's a few of those going on. There's at least one CIHR grant I know of from Dave Hammond in Waterloo, who's going to be prospectively evaluating what's happening before and after legalization, compare that with some American states and some other countries. But we may have a little bit of time because the implementation of this will take some time. But the baseline, pre-legalization, is actually, I think, having gotten good data, and it's good to know that StatsCan is doing something, but I'm just afraid that we may have had a window of understanding where we are right now, and then we make this nationwide policy change. If we don't have good baseline data of before it happens, how do we interpret what happened, right? So I think that's just, we have to keep that in the back of our mind and keep saying, rigorously, how do we evaluate this? How do we turn it into good evidence-based policy? So I think your point's really well taken in that respect.
And what I'm hearing is who's responsible, right? How do you transfer that responsibility? And yeah, it's true. We come from pan-Canadian health organizations that work with governments to help influence policy, both at the federal level and the provincial level, working with researchers. So we need that train of evidentiary stages, from research studies to getting interpreted into data, and data shared and translated to policymakers. It's a huge problem, not just in cannabis, but in health studies broadly. This is a really difficult task in mobilizing knowledge to influence policy. But I see now as a great opportunity to coordinate that as best we can, is what I'm hearing you say.
If I could weigh in also, I think that something that I see post-legalization is a tremendous opportunity, because the product will be quite different from the products that exist now, right? The plants that exist in the contraband market are essentially opaque. We don't know really what's in them. We don't really know their THC levels other than some of the confiscation studies. Once we know what people are consuming, and we actually have defined amounts, for example, we can do more surveillance work. But then on the medical side, something that's been very interesting is we've actually been approached by various electronic medical records companies that are actually mining patient data to try to find out what are the combinations that patients are using that have the best success. So I think that we're entering an era of very interesting new data that will often not be controlled the way we'd like it to be, but still may be very rich for generating hypotheses that then can be tested in rigorous clinical trials. And I think that we need to not have the blinkers on of only considering trial data, but think about all the sources of data that will be available going forward. Vikas, you had a question.
So I actually had 2 comments and 2 questions. I don't think we'll have time for both of those, but I think one thing, just because the main focus was more of the mental health perspective, one thing that we should also consider is the consequences to respiratory health. So we made a lot of progress with tobacco smoking and reducing rates of smoking, but I fear that once we promote legalization, or not promote it, but once it is legal, individuals will experiment, and then we may have further increases in smoking and consequences 5, 10, 20 years down the line. A lot of the evidence to date is really mixed, because they couldn't really tease out the tobacco use from the cannabis use. And there is some support saying that perhaps it might have an anti-inflammatory effect, so therefore it's possible that there's some anti-tumor activity. We simply don't know that. So I think that's one big issue. I think moving forward to see as a measure of success? Do we see our smoking, at least cannabis smoking rates go higher? Or if there's combined tobacco and cannabis products, which I know in the illicit market there is, but whether or not it plays into a role in the future too. Bear in mind that I think just this past couple days or so, Altria, which is a parent company of Philip Morris, is in talks with merging with or acquiring Afria. So there is that cohesion together of those two markets. Another point too is I'm not sure what the panel's opinion is on cannabis beverages infused with alcohol. I know individuals do it regardless anyways, separately, but what consequences that may have with the concurrent use of those two products together. And I guess I think I'll just let the panel talk about that. Plus, I was hearing some possible talk of marketing shatter wax. These are high potency products. I'm not sure if that's true or not, but there is some talk of whether or not that will also enter the recreational market. So what the panel, what's your opinion on those things?
So maybe I can start. It's my understanding that the cannabis-infused beverages will not include alcohol. There's talks about beverages including cannabidiol. There's beverages that include THC, but I don't think there will be any mixing in the regulations of the alcohol with cannabis, because we know when you mix the two together, it really increases the risk for impairment, but also some of the other cannabis-related harms. The question you raised about some of the other cannabis products, shatter, other products, the government is now going to be focusing its attention on the edible products and other cannabis products that will be legal a year from now in the fall of 2019. So it's not yet clear whether shatter will be part of that, but we will wait and see. Take part in the consultation, start gathering that evidence so we can inform that policy decision. But I don't know if others on the panel.
My understanding, concentrates are not going to be legal. So they're going to be tightly controlling the potency of products. They're not going to allow for these extremely concentrated products to come in. I know that there are companies that have already tried to come into the Canadian market with concentrates. They've been told they can't. On the other hand, there was just a report that came out maybe just last week showing there's a number of websites you can go to where you can purchase concentrates right now. Now, they're operating in a legal space, but there needs to be enforcement. And the other thing that's going to happen is you can take product that you purchase and concentrate it yourself. Right, and I think most people aren't going to do that, but people are doing it now with the illegal side. I think that's another place where education has to come in to understand the consequences of that. So I think it's going to be a combination. It's going to be ensuring that it's not overtly easy to combine these products, as you've heard with the drinks, that it's going to be providing products that are not of tremendously high potency that are available for recreational use. And it's going to be putting a lot of education into making sure people are aware of the risks of mixing different products and the dangers of going to these sort of higher potency things. One other thing I'll state too is you talked about the increased risk of smoking cannabis and the consequences that might occur from that. We don't know. It's an important thing to follow, but what we have seen in jurisdictions in the states where they've either decriminalized or legalized cannabis, there is an interest in a broader range of taking that product in. People move to oils and edibles and other routes. So there does seem to at least be some observational evidence that it might reduce rates of smoking cannabis once it becomes available and you can do more things with it.
There are also interesting questions about how the introduction of legal cannabis reduces alcohol consumption rates, which may have many downstream consequences in terms of acute and long-term health outcomes. And possibly, although it's not causal, there's some evidence that there are reductions in pain management prescriptions in those same catchment areas. So I think that it'll be critical to do some of these natural experiments too, in terms of looking at how the markets shift once there's a new recreational consumable available.
And again, it's going to, I think, come down to collecting good, reliable data on how, these combination products come together. I mean, I was a little bit dismayed, Jason, when seeing what the different commercial companies are looking to do. They're not all going to stick at the 12 to 14% THC content, right? There are some companies, I can't remember which one, that have applied for 30+%, right? So they're smart because they know the higher the THC concentration, the more likely their product is going to be embraced by the recreational user. And it's also, you know, I think, Amy, you're right in principle with these cannabis-infused beverages. You know, they're just supposed to contain that. But when beer companies or alcoholic beverage companies are lining up to get into that, I'm not confident that safety is going to be paramount here. So, you know, and then, you know, it's like a perfect storm. We have an opioid crisis. Let's not forget that kids are they're not smoking tobacco, they're using e-cigarettes, they're vaping. And these third generation e-cigarettes can be opened up, and cannabinoids, synthetic cannabinoids, or any ecstasy, any drug can be put in. So, you know, I think it's going to be important. You know, perception of risk is an important issue. The lower it goes, the likelihood that rates of use will go up. And, you know, so it's like there's a perfect storm coming here. And that's why we need data, and we need to manage this risk from a harm reduction perspective in a reasonable, transparent, evidence-based way.
Couldn't agree more. I just want to make a plug too for the qualitative collection of data as we unfold over legalization regulation. I think especially in this context of what young people are using to reduce harms, what young people are interested in using, needs to be done by talking to young people. So often policy is made without those subtle conversations. There's some good stuff happening across this country, and that unfortunately happens in qualitative study methods. So I think we need to focus on, yes, very robust data systems that can be shared across this country, but learning from the knowledge of people who use substances, and especially young people.
Hi, is the medical cannabis research here at McMaster, is it going to collaborate with people in Madrid and D.D. Meyer in Israel in order to sort of not repeat the same process? Plus there's 113 or 140 different cannabinoids that could have medical benefit.
Yeah, absolutely. So the purpose of the center is really to be an incubator. It's to bring together a lot of local talent that has a particular experience or interest in this area so that they work together. They don't all independently do the same thing. It's also to reach out to international partners. There's an annual conference that happens every year. The inaugural one was last year, where there was a number of international experts that did come and talk about their work they're doing. And there's certainly interest in those international collaborations and in building off of the last step in knowledge that's out there. But that's why it's critical to publish. It's critical to know what's been done so that you don't have 5 people doing the same thing in different areas.
Just to add to that, there is actually an initiative now to create a consortium of academic research centers studying cannabis for medical purposes. And part of that is because a number of these centers do exist in the US, where there's a very tortured legislative situation in which cannabis is a Schedule I drug at the federal level, but it's legal or legal for medical purposes at the state level in between 17 and 20 different states, depending on how you count it. So there are now the research centers there creating an international consortium that our center and other centers in Canada are becoming a part of, so we can try to avoid reinventing the wheel, but also develop capacity and scale by using our advantages at different universities and not trying to do all things in one place. I think we have time for one last question before we wrap up. Does anyone have a last question? The live streamers.
Yeah, just one thing to wrap up is I just would like to know what's coming next. What else is in the pipeline? There's obviously an almost unlimited number of avenues of research that could go on these fascinating questions, but what have we got next?
Well, I'll go first if you'll let me. So I will say that the DeGroote Center for Medicinal Cannabis Research will be holding its 2nd annual conference in April, and we hope that people who are here today choose to come to that also. We'll be presenting updates on the projects that we're sponsoring locally, but also focusing on the high priority populations, young adults, veterans, seniors, individuals with psychiatric disorders. So in April 2019, we'll be having our 2nd conference. And I'm sure everyone on the panel has updates they'd like to offer too.
Sure. Sorry.
Go ahead. I would just say for the commission, as I mentioned in my opening remarks, we just received this $10 million from the federal government, which technically actually hasn't been approved by the Treasury Board yet. So we're still waiting for that money to come to us. But when it does, we will begin investing in short-term research work through CIHR, working with some federal funding bodies to transfer money in short-term, year-long or 2-year-long studies, and then investing, as I said, in long-term team grants over the next few years. So you'll be seeing calls out there from the Mental Health Commission of Canada as a funder of cannabis research, looking specifically, of course, at a lot of the mental health questions. As I mentioned, over that time, we'll be building a knowledge hub with CCSA. Of course, a lot of folks, and one theme of tonight was sharing information, including data. And so I think we're going to be working with our partner and connecting with other partners on how do we share the outcomes of this research. Not much will come in the short term. Obviously, it will take a number of years before the evidence really emerges. But as it does, how do we coordinate it with CCSA and other folks across the country doing that work? So we have a program over the next 3 or 4 years really starting to begin this work.
So we also have quite a few exciting initiatives in the hopper at CCSA. So right now we are working closely with CIHR. We're co-funding a Cannabis Catalyst Grant competition. So we'll be funding some one-year projects focusing on priority research areas in cannabis. We're also going to be leading a new research policy network. I can't say a lot about it yet because it hasn't been announced, but hopefully we'll be able to talk more about that. But really the goal of this will be to be measuring the impact of the policy change and looking at various different indicators. Some other projects that we continue to work on, looking at drug-impaired driving, coming up with indicators of measuring the impact of drug-impaired driving. We are developing in partnership with the Seniors Coalition new clinical guidelines for the prevention, screening, assessment, and treatment of cannabis use disorder in seniors. So that's another exciting project that we will be hoping to release those new guidelines at the end of this year. Another key priority area for us is looking at young people and how can we further support public education efforts. So a lot of different broad areas that we're working on at the center.
And at the Schizophrenia Society of Ontario, we are hosting a series of community forums across Ontario, with our first one taking place at the beginning of November in Hamilton, with a foremost expert in the association between psychosis and schizophrenia, as well as a representative from a youth-serving organization. So continuing on the awareness front that way, at the government level is working with government as it works out its regulations following the passage of Bill 36. And informing that process as much as we can. We have a robust social media campaign that we've recently launched, and a great partnership with Epion, the Early Psychosis Intervention Ontario Network, who we are getting support from, and we're supporting their promotion and advocacy efforts. And we're also establishing a resource center on our website about where the facts, the stats, everything they need to know about cannabis, and where to get help.
Maybe just to add to that, I think faculty members at the center have submitted 11 grants for that Catalyst competition, so we're hoping some come through. In terms of specific projects, we're looking at formulations of cannabis for the treatment of chronic neuropathic pain in a trial that's led by Dr. Zacharias in the back and Vikas up here. We're looking at formulations for the treatment of sleep disorders, formulations to try to prevent persistent pain from developing after total knee replacement, which currently affects more than 20% of people that do undergo that procedure. There's studies underway as well looking to see if we can possibly use it, I believe, as a therapeutic intervention for some forms of psychosis. Am I correct in saying that? So there's a number of pilot studies that are in the works, and we're hoping to get those launched soon. A number of reviews out there to capitalize on the evidence that currently exists so we understand what is available. And there's some qualitative studies to try to get the experience of patients that have used cannabis for medicinal purposes, qualitative studies to talk to clinicians about the concerns they have about possibly getting into this space. And so there's a number of initiatives, and hopefully we're going to have more to talk about at the meeting that comes up at the annual meeting number 2.
That's right. Thank you very much, everyone. I'd like to give our panel a round of applause.